Hello, everyone. My name is Gurjat Basra, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm very pleased to welcome you to this breakout session on mantle cell lymphoma, also known as MCL. So just before we start, I do want to go through a few housekeeping items as usual. So this Zoom software does not allow you to access chat features or turn on your microphone. So if you have a question, this session will be followed up with a live Q&A session. So please keep your questions in mind and be sure to attend the mantle cell lymphoma Q&A afterwards. And to introduce our speaker today, we have joining us Dr. Mary Margaret Keating, who is a hematologist and clinical associate professor in the Department of Medicine at Dalhousie University. She completed her hematology training at Dalhousie in 2011, and her clinical practice is focused on lymphoma, patient care, and clinical trials. Dr. Keating holds a master's in medical education from Acadia University and has an academic focus in medical education and has had a number of leadership roles in education over the years. So thank you, Dr. Keating, for joining us today, and you can get started as soon as you're ready.
Perfect. Thanks so much for inviting me to do this talk this year on mantle cell lymphoma. Certainly a lot to talk about, and the title really does describe what's been going on in this disease. A lot more options, a lot more hope, and we'll take the next 40 to 45 minutes to review things. First, some disclosures. I have and do work with a number of different pharmaceutical companies when they're bringing drugs to market. Some of that is consulting and giving opinions on the trial results, etc., and some of it is research funding overall. So important to know that a lot of the drugs that I'm talking about, we've done clinical trials with and have worked with the drug companies with those. But certainly I try and keep everything as unbiased as possible when we're reviewing what's going on and what's new. So our goals for today are to understand what mantle cell lymphoma is. Many of you probably already know that. Learn how doctors choose your treatments. Hear a little bit about new first-line treatments, so the first type of treatment you might get as a patient with mantle cell. Explore what happens when your mantle cell comes back, what treatment options are looking like. See what's coming next in clinical trials and research, and hopefully end up leaving feeling more informed and empowered for the future and this disease. So I have just a few background slides, a little bit less than my usual because there is so much new information in treatment of mantle cell lymphoma, but I did want to go over a little bit of background to understand your body's lymphatic system, which is a crucial part of your immune system and really helps usually protect you from infections and diseases. So this is just a cartoon of your lymphatic system with all the little orange round dots there being representative of lymph nodes, and the channels that connect those would be lymphatic ducts. And then it's pointing out also your bone marrow and your spleen, which is the tiny little orange spot in the left upper side there. Those are all parts of your lymphatic system. And so there's over 500 lymph nodes connected by lymph vessels. Your bone marrow is where your blood cells are made. And then also your spleen, your tonsils, which are at the back of your throat, and your thymus gland, which is in the middle of your chest there, all is part of your lymphatic system. Your lymph fluid that runs through this system is filled with white blood cells, fats, and nutrients. And it has a lot of key functions to recognize and destroy infections, as well as early cancer cells that might form, and it helps control cancer in a way. It also helps manage fluid body levels and how you absorb your dietary fats from your bowels. So a pretty important system that does run all throughout your body. Your bone marrow is where your blood cells are made, and it's inside the spongy parts of your bones. So your red blood cells carry the oxygen around, your white blood cells fight infection, and your platelets help clot the blood. Your lymphocytes are a type of white blood cell. And so this organ is very important, and often mantle cell lymphoma does involve the bone marrow. We'll talk about that a little bit later, and that's when the cancer white blood cell actually starts growing inside the bone marrow as well, as because that is part of your lymphatic system. So there's lots of different blood cells, as I mentioned on the last slide. The yellow arrow is pointing to a lymphocyte, and a lymphocyte is the type of blood cell that when it turns into a cancer cell because of a mistake made within its DNA when it divides, that turns into lymphoma. But because there are a few different types of lymphocytes in our body, and then a lot of different developmental stages for the lymphocytes, that leads to many different types of lymphoma, which is where things get a bit confusing for people. But the lymphocyte is the key cell that is your normal precursor to your normal cell in your body. And that is the one that can turn into a cancer cell when you have mantle cell lymphoma. Why that happens, we don't entirely know. It's probably a multitude of factors. It's definitely more common as you age for there to be mistakes when your white blood cells just divide and grow normally. A mistake can be made in the DNA when that division happens, and that creates a type of cancer like lymphoma. Sometimes if you have other diseases that weaken your immune system, that can increase your risk of lymphoma. Certain infections, and there's a list of infections there I don't want to go through in detail, but any of these viral infections can slightly increase your risk of lymphoma. Or if you have a strong family history of lymphoma, we're learning just a little bit more about that in the last number of years, that there is some families who do seem to have a bit of a predisposition to develop lymphoma. But it's probably a number of factors working together when these diseases develop, and we can never really pick out when it started or what exactly drove it to happen, which is difficult for people to understand, and even us as physicians to understand why these start. So as I mentioned, there's many different types of lymphoma. In the lab, the pathologists, who are the doctors who diagnose these for us when we give them the samples, divide lymphoma into Hodgkin and non-Hodgkin lymphoma. That's based on what they look like under the microscope. And then non-Hodgkin lymphoma is divided into slow-growing and fast-growing types of lymphoma, as well as into what we call B and T cell lymphomas. But in reality, it's much more complex than even just that small diagram, because there's 41 different types of B cell non-Hodgkin lymphoma, 27 types of a T cell or NK cell non-Hodgkin lymphoma, and then 4 types of Hodgkin lymphoma. So really important that you have an expert hematopathologist, that's a blood pathologist, reading your case and ensuring that we have the right diagnosis of lymphoma for you. And as your hematologist and lymphoma experts, that's the first thing we are checking to make sure we're happy that we have the correct diagnosis, because different treatments are available, and different prognoses and conversations we have with people depending on the type of lymphoma they have. In terms of how common lymphoma is, these stats are a little bit old through Canadian cancer, but non-Hodgkin lymphoma, you can see here, is the 5th most common cancer in Canada. I believe that's still the same today, with somewhere over 8,000 cases, and probably higher than that now with population growth in Canada, compared with lung or breast cancer, which are much more common. And when we talk about non-Hodgkin lymphoma, that's all of the non-Hodgkin lymphomas grouped together, whereas those other 3 right after, leukemia, myeloma, and Hodgkin lymphoma, are some other types of blood cancer that are a little bit less common as a group. And this is a bit of a busy diagram, but just to give an idea, in the types of lymphoma, Hodgkin only makes up 17% of lymphoma overall, and non-Hodgkin lymphoma, the big group of other types of lymphoma, are 83% approximately of all lymphomas. And the little black box over the 4% and the little black box at the bottom there are showing that mantle cell lymphoma makes up 4%, 4 to 7%, depends on what study you look at, of all non-Hodgkin lymphoma. So it is one of the more rare types of non-Hodgkin lymphoma, but certainly common enough. There's a lot of research and a lot known about this disease. So not the most common non-Hodgkin lymphoma, but it is, we do see enough cases of it that it is fairly well studied, which is great news. Again, more of a transition slide, a bit busy and more sciencey. But again, when people ask, well, what's the difference between these lymphomas? That the round circle here with the light blue, that's a caricature of a lymph node, really. And the MCL that you see At the bottom of that, the little gray with the purple middle, those are lymphocytes, so the white blood cell. And basically, if the lymphocyte, when it's in the blue part of the lymph node, so the outside of it, something called the mantle zone, when the lymphocyte in the mantle zone becomes cancerous in that region and that point of development of a lymphocyte, that's when it's mantle cell lymphoma and not a different type of lymphoma. So it's a very specific timing in the lymphocyte development in your lymph node within your lymphatic system, that when that mistake happens at that particular time, that's when it's called mantle cell lymphoma. Whereas if the error in the cell that creates a cancer cell happens in other points of the lymphocyte development, it becomes different types of lymphoma. So not really meant to go through all of those in detail, but just to give you an idea, it's really about when and where the cancer develops within your lymphatic system that creates the different types of lymphoma. And so we'll talk a little bit more specifically about mantle cell lymphoma. So the basics are that it's a B cell, that's just the type of lymphocyte, non-Hodgkin lymphoma that develops in the mantle zone of a lymph node, and those cells become abnormal and they start multiplying. As mentioned, it's 3 to 10% of all non-Hodgkin lymphomas, different numbers from different studies, so relatively uncommon but well studied. And it usually affects older adults with the average or median age around 65 to 70, although it can occur at any age. And as mentioned, it gets its name from the mantle zone of the lymph node, so the outer region of it, where those B cells develop and change into a cancer cell. This type of lymphoma historically was classified as a slow-growing lymphoma, but really is a little bit in between. It's more intermediate and can sometimes behave a little bit more fast-growing. And often it needs treatment at diagnosis. I'm going to talk a little bit about that a little bit later. In terms of mantle cell lymphoma, the treatment goals, when you have mantle cell lymphoma, the goal is to achieve a remission. Remission means we've eliminated detective lymphoma cells. And if your blood counts are abnormal or there's been abnormal lymph nodes, that things have gone back to normal. The goal is to make that remission last as long as possible, and have you live a normal life in those times of remission, ideally, and really maintain that quality of life. And then, plan for the future, be aware of what our options are for later on, because we know that this is a treatable disease with a number of different treatments, but classically not curable. Like there's no single treatment that easily can make this go away forever, which is a hard thing to get your head around when you're diagnosed with cancer. But over the years, since I started working in 2011, this certainly has become more of a longer term chronic cancer compared with when I first started working. The treatments were much more limited, and so survivals were really quite short on average, compared with the last 10 years when we've had a lot of improvements, which has been really great to see. So in terms of understanding your personal outlook, it does depend on a number of different factors that your healthcare team overall will look at together. And some of the things they'll look at is the stage of disease, where your lymphoma is at diagnosis, specific features like are there things within your pathology sample that make your doctor concerned that your disease has higher risk and will need treatment earlier. Things that we look at, and I didn't want to get into too many fancy pathology terms, but we look at something called TP53, something called blastoid variant mantle cell, and something called Ki67, which are things that are looked at by the pathologist to tell us if your disease has risk to grow faster, and may need some specific different types of treatment. And we look at your age and overall health. What's your fitness level? And that's not like how fast do you run 5K? It's more, do you take care of yourself? Do you do your own grocery shopping? Do you walk with a cane or walker? Do you need a lot of help with your daily activities? And also knowing your other health conditions is very important. Have you had a heart attack? Do you have lung troubles or kidney troubles? And then in terms of understanding your response to treatment, like we try to predict a little bit how we think your lymphoma may respond to initial therapy. And when we talk about on average how well treatments work or how long on average remissions are, they are statistics based on clinical trials, and that's large groups of patients. And I always tell patients if I'm talking about an average or median survival or average or median remission time for a particular treatment, it doesn't help us know that that's exactly what's going to happen to a patient. Somebody could be in remission way longer than average, and some could be in remission way shorter. But it gives you a general sense of perhaps how well a treatment will work. So a lot of things we're looking at when we're trying to have a discussion about your prognosis or understanding what may come with your disease. I don't have a lot of slides about staging or biopsies or whatnot, but often PET scans are being used for staging and restaging of mantle cell these days. Compared when I first started working, it was always CAT scans. And some centers may use CAT scans, which is still okay. PET scans light up the lymph nodes brightly. So you can see where the arrows are pointing. Those are abnormal lymph nodes. There are certain things that do light up brightly on scans, like the bladder and the heart. So those parts are normal, but where the arrows are, those are scattered lymph nodes. And stage 1 disease would be when there's only one lymph node involved or one area, and you can see that to the far left of the screen. Stage 2 is when there's 2 or more areas on the same side of the diaphragm, so either all in the chest or all in the abdomen. Stage 3 is when there's lymph nodes involved above and below the diaphragm. So you can see in that picture, they're in the neck and then down in the left groin. There's 2 arrows. And then stage 4 is when there's lymph nodes in multiple areas throughout the lymphatic system, in the chest and abdomen, and often another organ involved. So in that picture in stage 4, there's actually spots in the liver as well. Or if the bone marrow or blood was involved, which is very common with mantle cell lymphoma, that would be considered stage 4. Stage 1 mantle cell lymphoma is exceedingly rare. And actually, I've only had one case, I think, of stage 1 mantle cell lymphoma. Most cases are stage 2 to 4, with the majority being stage 3 to 4, just because it often occurs in multiple lymph nodes and or spreads before we know it's even there. We don't know exactly which one of those it is, but most cases are in higher stage, which does not mean you can't do well long term. For sure, it's very different than other cancers. So it's not unusual for people to have stage 3 or 4 and still do exceedingly well long term. So we'll talk about treatment, and we'll be going through a few different parts in this treatment talk. So mantle cell overview. So because this is a treatable but non-curable cancer, we do know that some people can be safely monitored and not treated at diagnosis. And that only makes up about 15% of mantle cell lymphoma based on some trials that looked at this. Whereas 85% of patients with mantle cell lymphoma do need treatment right away, because they're either having symptoms from their lymphoma, or us as the physician are worried about the pace of growth or the areas involved. Whereas other slow-growing lymphomas, it's much more common that you can watch and wait and not need to treat right away. So that's the first thing that's a little bit different about mantle cell, is often, but not always, it does need treatment right away. When we think about treatment, over the years, it was always that your first treatment provided the longest remission when we were talking about standard chemo type treatments. And then often the next treatments you'd have over years would have shorter remissions each time. But with newer options that we're having, that sort of historical data that we always went by is changing a little bit. And so the first remission isn't necessarily always the longest remission anymore for mantle cell lymphoma. And modern treatments are really trying to focus on reducing the side effects or toxicity, but maintaining how well these work or hopefully work even better. So we'll get into a little bit more about watchful waiting here, even though it's not very common. So watchful waiting is what we call it. It's a medical term Lymphoma Canada and Leukemia Lymphoma Society use as well. But sometimes this disease can be safely monitored without immediate treatment. And people might have blood work every 3 to 6 months to monitor their blood counts and other markers like liver and kidney function. You might see your doctor every 3 to 6 months for a physical exam and to assess how you're feeling. And then scan timings such as CAT scans and PET scans would be determined on a case-by-case basis. We like to make sure our patients are aware of any new, persistent, or unusual symptoms they may be having, that we'd want them to notify us, any unusual pain that's not going away, weight loss, fevers, because lymphoma can present in a number of different ways. So yeah, watchful waiting, those numbers around 10 to 15% of patients. And in my practice, I would say it's fairly similar. I definitely have a handful of patients with mantle cell that I've watched on average for, I would say, somewhere between 3 and 4 years before the people need treatment. I have a rare patient who has had mantle cell for a very long time and has never needed treatment. But most patients, even on watchful waiting, will need treatment within a few years. And this is the minority of patients. But it is nice to avoid treatment if you don't need it. And if you have a slower type of mantle cell, better not to treat until we need to. Indications for treatment, I kind of alluded to a little bit. Certainly, if we are concerned about the pace or growth of a lymph node in a certain area, and we don't like to wait until somebody is having extreme symptoms to start treatment. It's a balance of not treating too early and not treating too late. But certainly if someone's starting to have some mild discomfort from lymph nodes or swelling interfering with normal function, certainly if we're worried about anything in the chest or lungs or anyone having difficulty breathing or swallowing, hopefully we've intervened before that. Blood work, sometimes we'll start treatment just because low blood counts develop over time because of bone marrow involvement, and or if there's kidney or liver issues, or less common but possible, weight loss, fevers, or drenching night sweats can occur as an indication for treatment. So treatment for cancer is getting much more complicated in a good way over the years, because in the past, all we had was chemotherapy and radiation therapy, and chemo just kills rapidly dividing cells. So chemo, quote unquote, had all your classic side effects of hair loss and nausea and vomiting and mouth sores, and radiation would be focused treatment to one area of cancer. Now we have more what we call immunotherapy or targeted therapies, and they're very specific drugs to target and kill your lymphoma cells while hopefully sparing more normal cells. So you're not seeing those typical side effects of hair loss and maybe nausea, although they do come with their own potential side effects. Nothing is risk-free. And our newest form of treatment, cellular therapy or transplant, certainly are other types of treatment that can be given. And we'll be going through each of these as we go through. So a key and I would say main advance in mantle cell lymphoma up until maybe the last couple of years, was these new pills called BTK inhibitors. And that's a brutin and tyrosine kinase inhibitor. I didn't want to write that all out. And they were a significant advance in treating mantle cell and really revolutionized care. And I remember when they became available in Canada around 2015, it just was like this amazing thing we had that we had this pill we can give to mantle cell patients and they'll do well for a few years after they've had chemo before, because that was not a possibility when I first started working. And they specifically target and attack lymphoma cells. They are approved in a number of different leukemias and lymphomas, these type of drugs. They do have fewer side effects, and much improved outcomes compared with traditional chemo. So I'm going to have a slide or two on this class of medication and then talk about how the use of these has been changing in mantle cell over the years. And this diagram, all these pictures I have in are all AI generated, so they're not science specific. But if you think of these purple cells as a lymphocyte and the red marker more what they would consider a BTK within the cell, and the green being the drug kind of uh, sitting on and blocking this BTK pathway on the cancer cell and causing the cancer cell to die. That's how these drugs work. Um, the first drug that came out in this category is called ibrutinib. It was approved for relapsed mantle cell lymphoma in 2013 and funded in Canada around 2015, and really became and has been and continues to be the standard of treatment for relapsed mantle cell lymphoma. So this was initially studied, and I have the references below. I don't know if anyone would want to look up the original publications, but they're there. The original study for ibrutinib was published in the New England Journal of Medicine, which is really the highest impact journal in the world, in 2013, showing its effectiveness in mantle cell lymphoma in patients who were heavily pretreated. They had many different treatments for their mantle cell before. There was 111 patients in the study, and they had high response rates. And patients who would previously maybe have lived a few months were living over a year or more. And these again were patients that really had no other options left. So it was approved and funded at that time. And then a second generation of these medications came out, meaning the same category of medication. It works on the same pathway, but these ones were what we call a little bit more selective. So they had fewer percentage side effect in terms of heart and blood pressure, and that's acalabrutinib in 2019 and zanubrutinib in 2021. So you'd never use these medications together because all three of these medications all work on the same pathway. And currently in Canada, the only funded drug for relapsed mantle cell in this category is ibrutinib. Both acalabrutinib and zanubrutinib were approved by Health Canada, but not funded because, from what I understand, Health Canada didn't feel that the studies, they felt that the studies with the second generation should have been compared with ibrutinib, but they weren't. And they felt that we already paid for ibrutinib, which was working well. So in the end, Canada just decided to only fund ibrutinib in this situation. Other countries would have the other drugs potentially funded. But these drugs aren't perfect, although they work very well for mantle cell lymphoma and really were game changing for patients. They do have potential side effects of a heart rhythm problem called atrial fibrillation. They can increase blood pressure, cause diarrhea, or have some infection risk. So again, nothing is perfect, but certainly a big change and opportunity for our patients with this class of medication. So in any cancer disease, when a new drug works really well in a relapse setting, because that's where drugs are always studied first when we don't know as much about them, it will always come to the next clinical trials would be, well, what happens if we give these really good new drugs to somebody with their first treatment instead of somebody later on in treatment? And so that's the next generation of trials that were done with these BTK inhibitors. And because they were proven to work really well in relapsed mantle cell lymphoma, researchers questioned, can we use them earlier? And there's a number of clinical trials that have been published just in the last couple of years, like really 1 to 2 years, that were testing these new drugs in combination with newly diagnosed mantle cell. And that's really where the treatment of mantle cell is going. And studies all have short form names, so I think so that physicians remember them better. So the clinical trials we'll be talking about have funny names like triangle, echo, and rectangle, and those are just short form names for these kind of clinical trials that have been done, that we'll walk through in a very basic way, hopefully, to just give you an idea of what's going on. So the evolution of these BTK inhibitors, these pills used in mantle cell, the first generation of ibrutinib came out in 2013, funded in Canada 2015. The second generation, acalabrutinib and zanubrutinib, came out in 2017 to 19, not funded in Canada, but are approved and often can be accessed through compassionate programs if the physician decided they wanted to use a second generation instead of a first for relapsed mantle cell. And in 2020, a number of trials were enrolling patients and and looking at outcomes of using these pills, these BTK inhibitors with chemo in newly diagnosed mantle cell to say, hey, can we get people doing even better early on? And really in the last couple of years, we're seeing a frontline shift that this is becoming the reality of treatment now, is that patients are getting these drugs at the beginning of treatments. So we'll review that, divided into age categories a bit. So in terms of your first treatment journey, meaning what happens when you get your first treatment for mantle cell, we always consider your age and your overall health, which I mentioned a little bit earlier, because we really want to find the right fit for everyone. And how doctors decide on the treatment intensity depends. Age does matter, although fitness is important. The clinical trials done for certain types of treatment are usually divided, that patients under age 65 to 70, depending on the study, versus those that are greater than 65 or 70, may be able to tolerate different types of treatment. Younger patients being able to tolerate more intensive approaches, and older patients may be needing something effective but less intensive. And so we do look at age, but also heart, kidney, liver, lung function, how well you take care of yourself, what's your fitness, do you need help with your day-to-day activities? So we're looking at all of these things when we're considering our treatment options for you. And we really just want to find the most effective treatment that you can actually get through and tolerate. So we'll talk about the journey for older patients or younger patients who may be a bit unfit. And when we use the term unfit, we may mean that their heart function isn't good, or maybe they're on dialysis, or maybe they have liver troubles. So that's kind of the medical term for having other health issues, but maybe being a bit younger. So our standard treatment for really most patients, but definitely our older patients, is something called bendamustine and rituximab. Bendamustine is a chemo, rituximab is immune therapy. This treatment is given once every 4 weeks for 6 cycles, and then often people will go on to have maintenance rituximab every 3 months for 2 years. So that's the current standard pretty much most places across Canada and in the world for an older patient with mantle cell lymphoma for your very first treatment. An emerging option for the same category is based on one of these clinical trials that's been published recently, called the ECHO clinical trial. And this looked at the standard of care, so bendamustine and rituximab, in one group of patients with mantle cell. And then the other group received bendamustine and rituximab plus one of these new pills called acalabrutinib. And then they looked to say, well, how did people do? Just to talk a little bit more about the standard. So the standard, again, bendamustine rituximab, kind of went through this a little bit, but bendamustine is given 2 days in a row every month, and rituximab is given 1 day every month. And then you do 6 months of treatment, so 6 cycles, and then 2 years of maintenance rituximab. And this combination has been the backbone for probably since 2014 in Canada. Before that, we used something called RCVP, which is similar but slightly different. It's well studied, big clinical trials done for this regimen in mantle cell, and well studied, effective, and generally well tolerated. It's kind of a lower dose chemo regimen. So was chosen because it works well. It has potential side effects, but usually a little bit less than other regimens. And we know the safety profile very well, and it's outpatient. So it's really a very important treatment option because it provides good control with manageable side effects, and we can use it up to very older ages. Maintenance rituximab, which is what you get just the immune therapy, 1 day every 3 months for 2 years after the 6 months of chemotherapy. Many trials showing that this keeps you in remission longer, and some survival benefits even in patients who get maintenance rituximab versus no maintenance rituximab. And so maintenance rituximab we do recommend in mantle cell lymphoma. And there are, again, potential side effects like infection or fatigue sometimes after the injections. Yeah, we just try and keep that first remission lasting as long as possible, and really has been standard for 10 years probably in Canada. So adding new drugs to our standard of care is the main thing that has been looked at in the last couple of years. And this recent clinical trial published in 2025 did show improved outcomes. So average remissions and median remissions, when I talk about that, it means half the patients were in remission longer than the median and half shorter. So the combination with the new drug, the remissions were 5.5 years median, and without the new drug, it was four years. And so that was considered statistically significantly longer. And so that this drug combination of bendamustine rituximab with acalabrutinib has been approved by Health Canada, and it's pending funding decisions right now. So the Canadian government and funders has to decide if they think adding this pill to newly diagnosed patients is worth the money, and is the outcome improved enough to do that. And so those decisions usually take about a year or two to make, if you can believe that. So we probably won't know that for a little bit yet. But we do have a compassionate access program, or not we do, but you can access acalabrutinib. And so if I had an older patient who had needed treatment for mantle cell, I could decide and chat with that patient about using bendamustine rituximab alone, which would be the standard of care. And I could talk to that patient about the option to add on acalabrutinib as with their first treatment. And actually, I did have that conversation with a patient recently, and we are going to use the triplet combination to try and get the longest remission the first time around. And that's really what we're looking for, especially in older people. So the evolution of treatment, 2012 or onward, bendamustine rituximab has been the standard, and 2025, we're wondering if bendamustine rituximab plus acalabrutinib may become a new standard. Again, it's pretty hot off the press, so we don't know exactly if that will be funded, but it's definitely a new improvement that we have. So for younger patients, I'm being cognizant of time here. I'll talk a little bit about what's new for younger patients. So our prior standard for patients generally less than 65 for the last 10 years, so since around 2015, patients would get multiple cycles of intensive chemotherapy as an outpatient. I'm not going to write the details down here. And then the goal would be to get to a type of stem cell transplant called an autologous stem cell transplant. And then they'd have their maintenance rituximab, the same as the older patients after they've recovered from the transplant. And this was a very effective treatment regimen, but very intensive and really not super fun for patients, especially with some of the intensive chemo and the transplant, a lot of significant side effects. And it still wasn't curative. So we want to keep that in mind when we're looking at newer research and the goals of that research. And so this intensive standard was used for younger patients because prior studies had shown average remissions were maybe around 7 years, which was quite a long time. So we felt that likely these intensive regimens were worth the risk for patients. And obviously that's a discussion to have with every patient about the pros and cons. And so limitations: very intensive, required hospitalization for transplant, not curative for patients, long recovery times, risk of later complications. So certainly this was the standard for a very long time, but the goal was really to try and have less toxic therapy that worked just as well. And so in came those BTK inhibitors again, and clinical trials done to find out if adding these early on would help our younger patients too. So the Triangle trial is just the name of the clinical trial that was done. And this trial answered that question, and it was actually published in 2023, and then the 4.5 year follow-up data from that study was presented at a major international meeting in December of 2024, so very recently, just last December. And basically what that study did was compare, it was a huge study, over 800 patients with mantle cell lymphoma who were fit and young, were randomized to one of 3 arms of treatment, either our standard treatment, like what we do normally, the high dose chemo with transplant and maintenance, or they got the same treatment plus ibrutinib, which is that new pill, or they got the same treatment plus ibrutinib, but no transplant. So there was one group who didn't get a transplant. And what this study told us is that adding ibrutinib to chemo significantly improved remission times, which was compared to traditional treatment. And the group who did not have a transplant did just as well as the group who had the transplant, as long as they got the ibrutinib. So this was the first study that told us we can safely avoid doing a transplant and still achieve excellent outcomes. And the survivals were actually 10% higher in the groups who got ibrutinib, regardless of transplant or not. So really, this has been a major game changer just in the last 6 to 8 months in the treatment of younger patients with mantle cell. And adding these BTK inhibitors to chemo seem to mitigate the need for a transplant. And 4.5 year follow-up data is pretty long. Obviously, we always want longer data, but having a 10% difference in survival is a big change for patients. And significantly fewer side effects compared to with transplant versus no transplant. This approach of treatment is not funded yet in Canada. That is another thing that will be looked at. There is a compassionate program to use ibrutinib in patients with mantle cell lymphoma and avoid transplant. So physicians and treatment centers have to decide what they want to do, because this is all very new data that we all have to digest and understand and really kind of go through and make sure we trust the data. And this was a very big, well-run study. So really the best kind of data we can get for a fairly rare disease. We're getting there. So one study I did want to mention is an ongoing study in Canada, and our center is one of the studies enrolling in this. And this is called the Triangle Study. And basically this is just building on the rationale of the triangle study. Sorry, this one's the rectangle study. The triangle, our current study is doing slightly less intensive chemo with a second generation BTK inhibitor called acalabrutinib and avoiding the transplant. So very similar idea to the very large study that was done, but it's using the second generation BTK inhibitor. So we're hoping even less side effects potentially. But this is enrolling in a number of sites in Canada. And so hopefully we'll have this data in the next few years. But we are having a lot of interest from patients in this because you get access to that newer drug up front and you avoid transplant. So always nice to have trial options when they're well designed. So in younger patients, we previously had this intensive chemo with a transplant and rituximab maintenance from 2016 to now. So again, the last 10 years almost, that was our standard. Now in 2025, this triangle study has been freshly published and it showed remarkable results, really. So although not funded yet, this is an option for treatment. And in our center, many patients are enrolling in this trial, which is a very similar idea to the one that was published, but using one of the newer oral BTK inhibitors. So when your mantle cell comes back, and it does, I mean, some people may have what we call a functional cure. If you're in remission long enough, you may not have an end of life issue with mantle cell. You may die of other natural causes or other issues, but often people's mantle cell will come back within their lifetime, and we have to think about what were they given before, what's their fitness, and what's their age. And at relapse, we're considering a number of different options now, and I'm going to take us through some of these as we go through the next few slides. I think I have 5 slides left here. So in Canada, over time for relapsed mantle cell lymphoma, in the earlier 2000s, we had limited options, short remissions, and a lot of side effects. It was really just traditional chemo, which is why the survivals were quite short with mantle cell on average years ago. In 2015, we really had the BTK inhibitor revolution, which transformed the treatment of relapsed mantle cell lymphoma and is still a standard. Now we have the emergence of CAR T since 2025, and maybe a year or two earlier, depending on the province you're in. We've had that funded in Nova Scotia since 2025, which is a new cellular option. And then ERA 4 is 2025 and beyond, where we have multiple new options being studied and potentially approved. So funded treatment right now in Canada for relapsed mantle cell would be the BTK inhibitors like ibrutinib, CAR T cell therapy, and allogeneic transplant. Those would be the funded right now options. We talked about BTK inhibitors quite a bit already, so I'm not going to mention too much other than to say in Canada you can get ibrutinib through standard funding, and then the second generations, if your doctor wanted to use those, they'd get it through a compassionate program. So key advantages of these drugs: you can use them as a single agent in relapse. They're oral. There's no IV infusions, and they can potentially provide years of disease control for patients. CAR T cell therapy is a complicated process. You do have to be fit for CAR T cell. There's not a specific age cutoff, but each center will have different assessments that need to be done or required to ensure someone's fit enough for CAR T, as this requires some chemotherapy and then a special collection of your T cells, which are your immune cells, and then your T cells are sent away and engineered to try and engineered to recognize your cancer cell, and then they're reinfused to kill your mantle cells. And that infusion and follow-up happens in hospital as an inpatient to watch for side effects. And so this is Health Canada approved and funded for mantle cell lymphoma, and it's after you've had a BTK inhibitor and prior chemotherapy typically. So it's usually a third line treatment or later for mantle cell, but really revolutionary treatment for mantle cell really available now. Still not clear or certain that this is curative because the data is still fairly fresh, a few years out, but certainly we're seeing long-term remissions with CAR T cell therapy with what we call the median progression-free survival with this particular type of CAR T, just over 2 years, meaning half the patients are in remission longer than 2 years and half shorter than 2 years after this treatment. So in interest of time, I already mentioned the eligibility is case by case. There are excellent response rates. It's available. So certainly ask your physician if you're getting close to third line therapy, if this is something that might be considered for you. Allogeneic stem cell transplant has fallen a bit by the wayside in mantle cell for a good reason, because we're having more and more other options. An allogeneic transplant, which is a transplant from somebody else, a bone marrow transplant, has high risk potential to cure mantle cell lymphoma, but really risks of really life-threatening side effects and potential ongoing quality of life problems. So really would be kind of usually a last option in a healthier, fit, younger person, if we didn't have other treatment options, would be considered. And then just one final slide or two on clinical trials. Clinical trials are available at many centers in Canada and good to consider and ask about. There's been a few clinical trials just published recently in relapsed mantle cell lymphoma. So ibrutinib, which is a standard for relapsed, there's a clinical trial looking at that in combination with a new drug called venetoclax, and they did find superior results with the combination of the two. And this was what we call a randomized placebo-controlled study, so the best kind of study that we can get data from. Not funded in Canada yet, but again, there's a compassionate access program. So if I wanted to start a relapsed mantle cell patient on this combination, I would be able to right now, pending the Health Canada decision on funding. This is the newest BTK inhibitor in the block called pirtobrutinib. It's what we call next generation BTK inhibitor, and it's meant to be used in patients who've been on a prior BTK inhibitor, like any of the three I mentioned, ibrutinib or zanubrutinib or acalabrutinib. Health Canada approved, but not funded yet. So this is something we'd consider for an older, unfit patient who's not eligible for CAR T, or maybe somebody who's already had those other type of treatments, we could consider as well. Again, compassionate access currently. And then there's other drugs as well. We've had clinical trials in most of these areas. So bispecific antibodies, sonrotoclax, another pill, and zilovertamab, and even studies looking at chemo-free approaches in new mantle cell. So lots going on in mantle cell, which is very exciting. So always good to ask your hematologist if there's a clinical trial available that's good for your situation. Sometimes there's not. Sometimes we have a study open and it's not appropriate for anyone. And sometimes we have the timing that works out perfect for someone, which is great. Um, so progress and hope. I mean, really, mantle cell lymphoma is really, I find one of the most interesting lymphomas for me right now because there's just so much advancement and it's just so nice to see for patients the options we have for them in a disease where we previously did not have good options. And so lots of breakthroughs coming. We have 5+ new classes of drugs being looked at, really more choices than ever before for patients. And although the diagnosis is serious, there's no question about that. It's nice to know that there's so much research being done that's really changing in real time for patients. So I think I went a little bit over time, but thank you for attending. And there's so much more we could talk about in this area, but I had to keep things short. So please attend the Mantle Cell Lymphoma Q&A if you have specific questions.
Thank you, Dr. Keating, for that fantastic presentation. As you already mentioned for the audience, the Q&A will be starting in a few minutes, so please maybe stretch a little bit and then make your way over to the Q&A, and I hope to see you there. Thank you.
Thanks.